let's do the level 2 part of ischemia. So there were 3 buckets in level 1: normal, T-wave inversions and ST changes; ischemic, T-wave inversions and ST changes; hypertrophy, T-wave inversion and ST changes. All right, let's look at the 3 other buckets. So this bucket is electrolytes and other specific conditions, and I'm going to go over those in the other section. So there are a lot of conditions that can cause problems with the T waves and the ST segments, and I'll talk about those in the other section. Left bundle branch block and right bundle branch block both cause ST T-wave abnormalities. Left bundle branch block, the T waves go in the opposite direction of the QRS. That's something to remember. When you see in lead 1, you've got this big wide complex, you're expecting the T wave to be upside down in lead 1. Same goes for lead V1, where it's mostly a big negative complex in left bundle branch block, and then the T wave is in the opposite direction. So that's something to remember, that T waves are in the opposite direction of the QRS in left bundle branch block. In right bundle branch block, you get ST depression and T wave inversions in V1 to V3. So it'll look something like this: ST depression, T wave inversion. Another bucket for ST and T waves. This is the garbage. Just like there was garbage for nonspecific intraventricular conduction block, there's the garbage for nonspecific ST T wave abnormality. And this is one of the more frustrating parts of ECG reading. I think for students and residents, the reading doctor will call a lot of stuff nonspecific, and the student might say, well, how do you know that's nonspecific? What's the definition? It's not really very well defined, so it's pretty arbitrary. The clear line between nonspecific and specific isn't really there. If you want to be strict about it, you can go back over here to the ischemic abnormalities, and if the T-wave inversion is less than 2 millimeters, or the ST depression is less than 1 millimeter, then you put that ST T-wave abnormality in the garbage. And unfortunately, it's just not that simple, because if you've got little QRSs, then a smaller amount of T-wave inversion might be more important than if you have a bigger QRS. But to keep it simple, we'll just say over here that that's how you define a nonspecific abnormality. If it's ST depression less than 1 millimeter or T-wave inversion less than 2 millimeters, then into the garbage. So here's a normal ECG. I wanted to show an example of a persistent juvenile pattern that I mentioned in level 1. The persistent juvenile pattern is T-wave inversions in V1, 2, and 3, and it's more common in sub-Saharan African ancestry, like 10% of people in that demographic, and more common in females. So, as described, there's the T-wave inversion here. And frankly, if someone were having pretty classic chest pain, anginal symptoms, and they had this ECG, and you didn't have a prior one, you wouldn't know if this were ischemia or a persistent juvenile pattern. But if someone weren't having any symptoms at all, then you might be more suspicious that this was the persistent juvenile pattern. Or if they had an old ECG when they weren't having symptoms that showed this, and now they're having symptoms and it shows this, then there's a high chance it's a persistent juvenile pattern. Here's an example of the nonspecific ST wave abnormalities. And this one's basically, it's showing flat T waves. So you're expecting to see a T wave like this and in all the leads. And we've got them in most of the leads, but in AVF, well, there's basically no T wave. So we're going to put that one in the garbage because it's not normal, but it's also doesn't meet criteria for ischemia. Now, level 2 infarct stuff. So I wanted to show you the signs of acute myocardial infarction, and the initial sign of an acute MI is hyperacute T waves. It's the first thing that pops up when somebody's having a heart attack. And these occur over a period of minutes. So when the artery becomes plugged, within a few minutes, you're going to get these hyperacute T waves, and they come definitely before the ST elevation. You see wide, tall T waves. It's the start of injury. And this ECG, it's not super prominent, but these are definitely wide T waves. They're pretty tall. They're not massively tall. I've seen cases where it's really massively tall. And there's a little ST elevation here as well already, so this isn't the greatest example. ST elevation over here in the lateral leads. So these T waves are kind of hyperacute. I guess this is probably the best one here. We're going to talk about some special cases for ST elevation equivalence. So we went over the basic stuff in level 1, where we talked about how in lead V2 and V3, the criteria are greater ST elevation determined to be caused by an MI as compared to in the other leads. This is expounding on that. So here are a couple of special cases. We've heard of posterior infarcts, probably. The posterior infarct shows ST depression. It's in V1 through V3 in at least 2 leads, at least 2 of those. So say you've got a 60-year-old woman who smoked forever, and she's having crushing chest pain, and she's got ST depression in leads V1 and V2. She's probably having an ST elevation MI and probably having a posterior infarct. So that's one special case for somebody's having an acute infarct, but they don't have ST elevation. Here's another one. So an RV infarct, or right ventricular infarct. You'll have ST elevation greater than 1 millimeter in V4R, and I'll show you what V4R is in a bit. That's a non-standard lead. You can have an ST elevation MI equivalent where there's an occult lateral infarct. So you otherwise can't see it on the normal 12-lead EKG, which has all the standard leads. And you get this occult lateral infarct when there's ST elevation of greater than 1 millimeter in leads V7, 8, and 9, again, which are non-standard leads. Then another instance of non-standard appearing ST elevation MI equivalent would be STEMI, ST elevation MI with a pacemaker or pre-existing left bundle branch block. I'll show you some examples, but that's going to be in level 3. Here's an example of a posterior myocardial infarction. It includes the lateral and inferior leads as well. So it's an inferior posterior lateral ST elevation MI. But you can have a posterior infarct alone, where the only finding you see is this one over here, where there's ST depression in leads V1, V2, or V3. So there's clearly ST depression in these 2 leads, and this would be enough if the patient was having the right symptom complex to diagnose a patient with a posterior STEMI. But this ECG also does show ST elevation in the inferior leads, which makes it easier. And there's a little bit of ST elevation over here in V6 and V5. So this is an inferior posterior lateral ST elevation MI. Here's the right ventricular infarct I wanted to show you. So V4R, you put it here. It's mirror image of regular V4. Just put it on the right side of the chest. You would do that if a person was having classic symptoms of myocardial infarction, but their ECG wasn't showing signs of infarct, or maybe there was just a little hint of a problem in V1. You could switch the lead from V4 and put it over here. And then if you saw this, there's about 1 millimeter of ST elevation there, you might suspect that the patient is having a right ventricular infarct, and that would be in the right clinical setting. So you can suspect that that's occurring along with an inferior infarct if you want to know if the RV is infarcting in the setting of an inferior infarct, but it's usually pretty obvious because if the patient has low blood pressure and a low heart rate, those things imply ongoing right ventricular infarct too. So you could suspect it with an inferior infarct or somebody having typical symptoms, and you check V4R, and if you see ST elevation, that tells you you're having an RV infarct as well. All right, changing gears from acute infarct, we're going to go into indicators of old infarct. In level 1, we talked about Q waves. Well, here we're going to talk about poor R wave progression, which is another sign of old infarct. And that's defined as R less than S in V4. So show that here in this sample ECG, where it's a little confusing because this is just the precordial leads, so there's no limb leads there. V1, V2, V3. So you get over to V4. By the time you're at V4, you're expecting the R wave to be taller than the S wave, but it's not. R is less than S. So that's an example of poor R wave progression. That's how it's defined. This is a very non-specific finding. So many people have it. it can be caused by obesity, lead misplacement, LVH, RVH, COPD, and then it can be caused by an old anterior MI, and that's why we pay attention. But in my experience, that's quite rare, and I'd say, 5% of people with poor R wave progression actually have had old anterior MI. It might even be less. So poor R wave progression is a possible sign of old infarct. It's defined as R less than S in V4, and it's very nonspecific. All right, let's do next one. Possible sign of old infarct. Early R wave progression. So that's defined as an R which is greater than S in V1 or V2. So it's kind of the opposite of poor R wave progression. You've got, again, we've just got the V leads here. We've got this tall R wave and a little S wave in V1. That can be analogous to a Q wave and can be a sign of old posterior infarct. The differential for R greater than S isn't as broad as it is with poor R wave progression, so that can be caused by RVH, WPW can cause that. Occasionally it'll be a normal variant, but it's not too common. And then the zebra Duchenne's muscular dystrophy can cause the R to be greater than the S. Of course, you're already going to know that the patient's got this problem, but it can cause that ECG abnormality. And this is a little more useful, probably, than poor R progression, because R greater than S in V1 is pretty uncommon. Oftentimes, it really is a sign of an old posterior infarct. Here's an example of an old posterior MI by the R greater than S in V1. We notice this because it's uncommon to have an R greater than S. In this case, there's no S. An R greater than S in V1. So when you're reading ECG, you're going to notice this. And you've got the same thing in V2, where the R wave's really quite tall. The S wave is small. We don't see RVH necessarily. We don't see strain pattern. We don't see like T wave inversions and ST depressions in V1, V2, V3. So rather than this being RVH, this is probably old posterior MI.